Well, good afternoon, everybody. This is Jeff Smith with Cohesion Chiropractic, and glad to have you with us for this month's Learn at Lunch session. Again, this month we've got Dr. Jeff Rich doing another session of his impacting patient care with chiropractic radiology. And from what I've seen, Dr. Rich has some interesting and challenging cases for you again this month. Just a reminder that if you're not muted right now, please mute yourself so that we don't get any background noise and feedback. But be ready to hop back on when Dr. Rich is asking you for your questions, comments, answers, or feedback. And then just a final reminder that after the session, I'll send an email to everybody that will have a link to the test, which if you pass the test with a score of at least 5 out of 6, then you qualify for 1 CEU credit. So with that, Dr. Rich, go ahead and take it away.
Okay, thanks, Jeff. Hi, everybody. How's everyone doing?
Great.
Doing okay? Do we have guys and gals today? Welcome. It's 70 degrees and sunny here in Minnesota. I hope the weather's worse there for your hour of radiology. I'll jump right into it here. I got some good cases for you today. I'll make sure that I cover the answers for the 6 quiz questions so that you can just pop on and take it right away and get your hour. But let me just remind you of kind of how we do this. It's really a hands-on. I like to do kind of hands-on radiology just to get you back practicing the 4Ds. Detection, we'll have some questions where I have you look around. I shut up, which is kind of nice, and have you just look around and try to find the abnormality. Maybe just describing it, and instead of asking you what the differential diagnosis is, but how would you describe this? Kind of if you wrote a report and had the body of the report, what kinds of words would be describing the finding that you're seeing? So we'll practice that, and then obviously most importantly, what does it matter that we even took the picture at all? How does it impact our patient care? What are the associations and complications of the disease that impact our patient care, whether or not we are straights or mixers? Whatever our philosophy of care is, we all want to know. We all want to know that Paget's disease results in high output cardiac failure and osteosarcomas and cranial stenosis and basilar lung fibrosis. We want to get to that final answer. And so I hope you enjoy it. A few good cases. They're all pretty fresh, pretty new, some boring stuff, but it's absolutely essential that we don't miss, and some kind of weird and wonderful things that maybe will wake you up. So if you have a cup of coffee, I highly recommend it. Grab your mug and sip away. Everyone, sip together. Okay. First case. 75-year-old male with deep, constant lower back pain. Deep, constant lower back pain. All right, now I'm not gonna flip to the picture yet, but when I do, you're gonna see it pretty fast, and that's fine. That's good. I hope you do. But what I want you to do is try to come up with 3 different differential diagnostic considerations. Not just one. Now, I hope we get at least one, like the main diagnosis, but let's try to think of 2 other things, and I'll let you guys give me feedback. Okay, so here you go. It won't take long. Lateral lumbar view. What do you see?
Aneurysm for one.
Okay, good.
Aortic.
So everyone agrees that there's an aortic aneurysm here. Jeff Smith, are you still with us? He might have jumped up.
Yeah, no,
okay.
I was just muted.
Okay.
What do you need?
Okay. Well, if you could help me know how to get the toolbar off the thing, just so it's hidden. I forgot how to do that, and I don't want to hit something and mess us up here.
If you can just click on it and drag it out of your way. I mean, we can't see it, but you can.
Oh, you can't see it. I'm not going to worry about it then. Okay, here we go. All right, so let's go back and reset this to red. All right, so there is the dimensions of the abdominal aorta, and this measured 7 centimeters from front to back. If I erase it, you can see the kind of the fusiform dot dash calcification of the atherosclerosis of the aorta there. This one measured 7 centimeters. What is the diameter above which we have an aneurysm? You guys remember, or I don't know even what Dr. Albers, if you were at Northwestern, Dr. Mick.
3.8.
3.5.
Okay, so yeah, good. So that was really specific. Those numbers are really good. I just stick with greater than 4 centimeters. Maybe I'm a clumper instead of a splitter. But the number I want you to know is if you're above 4 centimeters, then it's definitely an aneurysm. Okay. Now, there is a little grade 1 degenerative spondy from facet arthrosis. There's degenerative change here. There's some funky developmental changes at the back of the sacrum. All that's no big deal. That's why you're not talking about it. But let's see if you can get 2 other possibilities. Yes, an aneurysm, but give me a differential diagnosis for this appearance. Go ahead and give it a shot. Anybody?
Oh, you know, it sure looks like an aneurysm if you go a soft tissue mass or tumor then.
Yeah, good. So a tumor within the abdomen, and what would be unique about the tumor is it has rim calcification. And so the tumor would be more of a cyst type of mass. Whenever you get calcification that is kind of outlining the rim of something, you got to think of a calcified cyst. But renal cysts are nasty. You realize that any calcification within the kidney, within a cyst in the kidney, is cancer until proven otherwise. And so a big differential for aneurysms is renal cystic calcification, which deserves a CT scan, deserves to be considered cancer first and foremost. So that would be a good thought. So a tumor, so aneurysm, a cyst wall tumor. And because, this is pretty close to the spine, it's pretty close to retroperitoneal where a kidney cyst might be. So that's a possibility there. The other possibility would be, some calcification within the, I would just say mesenteric calcification or bowel content. Sometimes you get just calcification within the abdomen from bowel content from different foods or different things you eat that are radiopaque that I've seen look just like an aneurysm. So I like tumor for number 2, especially with rim calcification, thinking of kidney. And then I like just undigested bowel content. And the reason I'm making you do this today is just to remind you that we got to be careful not to be slam dunk radiologists. Basketball season's coming up. I'm going to use all kinds of sports terminology because I'm still so surprised and disappointed that Aaron Rodgers yet again brought the Packers back. But so we have to have 3 possibilities, 3 DDXs. So or else we get lazy and we begin to do slam dunk radiology, aneurysm, fibrous dysplasia. And I think we're safer if we think, okay, that looks like an aneurysm. Now, what could I miss here? Let's check it out. But you're right, this is an aneurysm. Very good. This one measured 7 centimeters. And by the way, what is the next best follow-up for this case? A patient comes in, they've got deep low back pain. It's constant. You're thinking it could be dissecting, potentially, if the pain's related to this. So what's the next best follow-up?
Diagnostic.
Emergency.
Yeah, Yeah, I agree that an ultrasound or CT, but someone mentioned ER.
Yep.
And I agree, because if they're getting pain that's constant and deep, and they describe it as deep, what they're saying is it's in my belly. I tell you what, guys, if you get constant deep pain with this X-ray finding, don't mess around and setting up a CT for 2 weeks. Send them right to the ER and let them get the ultrasound and CT. On the other hand, if they don't have that kind of pain, maybe you can just say, hey, I want you to go in to urgent care and tell them, here's my report that I have for you, and let them get a CT and just get going that way. I think that would be fine. All right, next case. Where is the finding? Now, this one is a detection case. Really hard. Just a reminder of how you do detection. I don't want to insult anybody here, but I told my students that discipline is how you do detection. You've got to be disciplined. And so I like to have a nice dark room. I like to hang the films up the same way every time. I use TABCs, technical alignment, cartilage, bone, soft tissue, but I look all the way through the soft tissues. Don't stop. You find a finding on alignment, like a big ADI, and we all say, hey, I've earned my $90 here. I'm done. No, keep looking at cartilage, keep looking at bone, and then look at the soft tissues. Look all the way through the soft tissues, and don't look at all 4 corners of the film. Don't just centralize. Look at all 4 corners of the film. And if you do that flow on detection, your hit rate will go from 60% to 95%. I kid you not. We've got research for this, that discipline in detection is really where radiology, the battle is won or lost. So I'm trying to help you for the next case because I'm nice. Where is the finding? I'm going to shut up now, drink some coffee, cry about Aaron Rodgers while you find the finding. There's an AP thoracic. Go ahead and look, and then you can start talking and tell me, just don't tell me what it is. Just tell me, hey, I see this. This is the finding. Go ahead and look. All the way through the soft tissues, all 4 corners of the film. Don't get search satisfaction. All right, you had a few seconds to look. Anybody want to start throwing some stuff out there?
Right lower lobe of the lung there, you got an air fluid level.
Okay, so this is, I'm going to go, let me just put this up here. I'm going to say this is the patient's left, this is the patient's right. So are you still wanting right lower lobe or left lower lobe?
Right.
Right.
Oh, okay, so are you looking right in here?
Yeah. Yeah.
Okay. All right, so what we have here is that's the diaphragm. We just got a nice a little bit sharper cutoff than usual of the lower lobe of the lung. This does look a little blunted here because there's cardiac fat that kind of makes it look funny. The cardiac fat almost makes this look like we've got a fluid level. So that's a normal variant. That's not the main finding, but it's actually a good pickup. Other stuff. Keep going. Say one more time.
Well, would you say the parts enlarged on the lower left, cardiomegaly, or do you think that's more of a collapsed lung over there?
Okay, good finding. Because this is an AP thoracic, then all bets are off with diagnosing cardiomegaly. Guys, this is worth the whole price. I don't know what you paid to be here for an hour, but this is worth the whole price of admission. Do not call cardiomegaly on an AP thoracic film. Only call cardiomegaly. I mean, it's got to be ridiculously big to call it. Otherwise, call it only on a P to HS film. Here's why. Number one, A to P causes magnification. Number 2, a 40-inch tube to film distance for thoracic causes magnification. With chest films, you're supposed to take 2 deep breaths in, and that reduces magnification. So if you get a chest film, you won't have, then you'll know if you have cardiomegaly, and this heart's normal. Okay, keep looking. Okay, look through the soft tissues. Look at all 4 corners of the film. Anybody see anything now? All 4 corners. Trace the edges. What pops now? Or at least you can't explain it.
On the
Right upper left.
side, way low, there's a soft tissue mass right below your right, that you wrote the right marker. Is that what you're looking for?
Yeah, this is what I'm looking for right there.
Yeah.
Now, some of you, I think, were just said this looks a little sclerotic right there as well. I think, you know, I might buy that. This is the main finding. You say, well, that's hard. Well, yeah, that is hard, but it just came through. And so that's the finding. And what's the next best follow-up to follow this up, in my opinion? You can say what you want to say. I'll tell you, I'm pretty sure I know the right answer here. What do you think?
Follow up that soft tissue mass? Or the
Yeah, right here. Just follow that up.
So would you want to do the AP chest then? To get
Yes. Yeah, do a P to A chest. That's really good. 72-inch, collimated out, the right KVP, a real chest film. All right, so that's good. That's the next best. Okay, somebody needs to get muted here. We're having some background noise. The next best imaging choice is a chest film, and there it is. Take a look at the case. So the same patient now, and again, here's the right, and you can see here, well, I didn't draw it right, but it's really a smooth, convex in sort of abnormality. And this is called, and you should know this for the quiz, this is called an extrapleural sign. An extrapleural sign. In other words, if you have an abnormality of the rib, a pathology of the rib, that the soft tissues expand, the rib has got something in it, and it sort of has a soft tissue mass that's pushing into the pleura, into the lung. It doesn't get into the lung, but it's pushing the pleura in. It creates that sort of extrapleural sign. It just kind of looks like that. And so that is indicative of a rib abnormality with a mass, a soft tissue mass. And sure enough, it was metastatic disease to the rib from cancer from I think the colon, and creating an extrapleural sign. And by the way, this ended up being a sclerotic pedicle as well, but I think that's a lot harder to see. So tough case, but I guess my whole point of just showing you this case is, it's interesting because it helps me teach detection. To really see it, you got to clear all 4 corners. You really got to look at the soft tissues, everybody, and you got to make sure you're not just centralizing, but you're looking at all 4 corners. And so aggressive pathology of the rib can show up as an extrapleural sign, and you get a chest film to see that. Good case. All right, mid-40s, individual with a history of old trauma, ongoing neck pain, and a clicking sensation. That's the history. Everyone got that? All right. I like this case as well. The last case was more of a detection. This one's not as hard on detection, so let's get it over with. And all you got to do to detect here is tell me what level, C2, C3, C4, C5, C6, C7, you get the idea. What level would you peg as the main level of abnormality? Anybody, just tell me what level you kind of are looking at.
C6.
Yeah, I agree. 2, 3, 4, 5, C6. I'm with you guys right in there. That's the level. But I want you to now instead of trying to diagnose this bad boy, I want you to slow down. Let's have some fun under the idea of description. So forensics. Don't get sucked into diagnosing this yet. I know that you want to, but I just want to remind you of the power of a good description and looking just the power of observations right around this area. So find stuff that you might put in your description in the red circle that is associated with that main level right in here. All right, go ahead and go, and I'll write it down for you.
Extension malposition of C6.
Okay. Extension of C6. Can you guys see my writing right there or not?
Yes.
Okay, good. Extension of C6, and I'm going to put flexion of C5 because both are happening there. And in fact, take a look at, well, I'll just let you guys talk. I don't know why. I already know this case. All right, what else do you see? Just forensics.
End plate abnormality, anterior end plate of C6.
Good. Excellent pickup. End plate is abnormal at C6. It's kind of looking like there's a Schmorl's node there, or it's irregular, whatever. I mean, well, whatever we might call it. What else?
Loss of anterior vertebral height at C6.
Excellent. You guys are good. You know why I like what you said is you have a tendency to just say a diagnosis, but instead, no. Let's just do the finding, which is loss of anterior vertebral body height. Excellent. I'm having a hard with my periods are causing it to move. I will forget putting periods on this. Okay, what else?
Mild osteopenia.
Yeah, there might be osteopenia here. I think a lot of this is related to the technical factors. They're pretty young, so I'm going to pass that.
40,
What
yeah.
else? Yeah, what else?
Facet arthrosis.
Facet arthrosis, okay. What else? Now look at the interlaminar spaces, the spaces posteriorly between the lamina. What do you notice?
There's some subtle posterior osteophytes into that IVL.
Yeah, there might be, although that would be better to see, yeah, right in here. That would be better to see, I think, on an oblique view. So I'm going to pass it because they're super subtle. So keep looking at the interlaminar space, or the distance between the lamina.
Well, it's increased.
What do you notice?
In 6.
What do you notice there?
Wouldn't you say that
Increased
more of that
between C4
flexion
and 5.
fixation?
Good. Yep, the flexion of 5-on-6, and then also, yeah, like you said, someone also said, and that's tied together, there's an increase in the interlaminar space of 5-on-6. It's wide there. But this is why I'm slowing you down. There's a wide interlaminar space. And you say, well, now, and let's put that all together now. If you've got flexion of 5-on-6 with a wide interlaminar space, with an in-plate abnormality of C6, with an anterior wedging of C6, and I tell you this, there's a little facet arthrosis and maybe even a little disc space narrowing at that level, and I tell you that there's been old trauma, what's the mechanism of the old trauma?
Probably axial compression and flexion.
Yes, axial compression and flexion. That's how we got the in-plate abnormality. That's how we got the widened interlaminar space. That's why we get all this stuff. I get excited about this because if we'd slow down and remind ourselves, not to just say compression fracture, and slow down a little bit, we would know that there's not just a compression fracture. The more significant finding is the flexion of 5-on-6 and really the sprain strain, and is that even stable or unstable? We need flexion extension fills films and all of that. So good, you guys got it, but I just want to remind you of the importance of old trauma. Flexion of a spinal segment, focal flexion of a spinal segment in the mid-cervical spine, according to the literature, is very indicative of old trauma, as you guys know. But I'm just going to say it because the research has proven it out. Look for focal flexion, and of course, extension, extension the level below, which is absolutely right, will be an indicative of old trauma. Okay? All right, good. Next case, no low back pain. Okay, this is a detection question. Just make the finding for me. What level is the abnormality here?
L3.
Yeah, I agree. Nice work. L3 would be your detection. All right, now, without giving me a diagnosis, let's do the harder step. Someone give me a quick description of the radiographic findings. How would you describe that if you were writing a radiology report in L3?
Calcific striations.
Okay, I like it. All right, now, everybody sitting there sipping their coffee, if they're not thinking about football and are paying attention, not looking at their phones, checking out the scores, just the doc saying striations. Come on, didn't that slam dunk the diagnosis for you? What if I'd say prominent vertical trabecular striations? How's that for help? What if I said corduroy cloth appearance?
Hemangioma of bone, isn't it?
Yeah, but you see how the description, yeah, because this is a hemangioma. But I'm telling you, if it's only a hemangioma, if your brain can say, wait a minute, those are prominent striations, and are able to like slow down a little bit and remind yourself of what you're actually seeing. And so, yes, I agree that this is a hemangioma. Typically, no big deal. In fact, typically the bone is stronger. It's only at one level. If that appearance was at multiple levels, then you'd have osteoporosis. That's exactly what osteoporosis looks like if it was at multiple levels. If you had this appearance, but the end plates were thicker, a little thicker, with that same appearance, you wouldn't have a hemangioma, you'd have Paget's disease. So really your differential diagnosis for this is hemangioma, osteoporosis, and Paget's. But of course, it's pretty classic for hemangioma because you just don't have it at multiple levels. You don't have thickened end plates. Now, hemangiomas about 2 to 5% of the time can go aggressive, and not as turning into cancer, but they can expand outside of the confines of the vertebral body. The bloody material can expand into and a lot of times they go in and they cause a nerve compression. I've only seen 2 of those, but just keep that in mind. All right, good job. See you check the time here and get on to the next case. All right, detection on this case again. Where is the finding?
Agenesis of the dens.
Okay, so that's a good diagnosis. It's but okay, don't worry about a diagnosis yet. Yep, I just want to know detection. So simple, you're all seeing it right at C2. I mean, C2 is abnormal. If I was given a case study for my students, and I do, this is the class I teach, the 4Ds case study approach, all they have to put is C2. Now, let's slow down a little bit before we get on a diagnosis. Take a look up here. And let me see if I can even make this a little bit bigger so we can see it. All right. So what do you see now? Try not to diagnose it. Just try to stay forensic on me. Is the odontoid process still there?
Yes.
Yeah, I agree. Especially when you blow it up, that it's still there. I'm kind of outlining it with the white finger there. Yeah, it's still there. So the main finding you're seeing is that, right? I mean, that's the thing that's, you know, there's lucency there. Is that the disc of C23? Is that the C23 disc?
Nope.
No, I mean, that's down here by the hand. It doesn't look fresh. There's two reasons that this doesn't look fresh, in my opinion. You guys want to tell me what they are? What are two reasons this doesn't look new?
Product border.
Very good. I agree that the borders are of that lucency there. They're very well defined. They're very smooth. They're very sclerotic. And then there's not a lot of inflammation here. I mean, I can tell you there's not a lot of inflammation. You say, don't you need an MRI for that? Well, kind of. But what's a good secondary finding here that says, you know what, there's probably not a lot of swelling going on here?
Vertebral.
Retropharyngeal soft tissue space.
Yeah, good. Yeah, look at that. I mean, that'd be pooched. If that was puffy and that was a new fracture or some sort of a, I don't know, lytic, kind of a linear, weird form of metastatic disease, I mean, you'd have a lot of swelling there. All right. So what view are you dying to see here?
AP, open mouth.
Open mouth.
Right. Good. I'm dying to see it too. So let's show you. Whoops. Isn't that the weirdest thing you've seen since breakfast?
Congenital abnormalities can do that to you.
Yeah, I'll tell you what. I mean, I think this is a great case. All right, now let's think about finally, right? Because this is like what we like to do, but I'm making everyone slow down to detect, to describe. Now, differential diagnosis. Let's get three things here, or I'll get the list started. You guys start. Give me three things you think this could be.
Non-union of odontoid.
Of what? Non-union from?
Secondary ossification center.
Okay, good. Secondary ossification center. Okay, because now watch this. It's not right at the base of the odontoid process. It's kind of swinging down into the body, and as you remember, the dental central synchondrosis. I just like saying that word. Dental central synchondrosis is not right at the base of the odontoid process. It's actually down into the body a little bit. Kind of this would be, so very good. I think this is a true non-union of the odontoid process. Differential diagnosis is, let's see if we can get at least one other thing. Well, I mean, this has a specific name. At least if you see just a smooth ossicle by itself right there, what would that be called?
Os odontoideum.
Right. So I think you got to be thinking, I admit that is usually a small ossicle, and this is kind of a pretty big deal here, but what else? Couldn't this be an old fracture?
Yeah, basically, because you see the, you know, the separation, but now it could heal that way.
Yeah, I agree. I don't like it for an old fracture, but I think if we force ourselves to be disciplined to try to think of three things, we'll be way better at integrating our radiology into our chiropractic practice. Because let me just say the truth about an osteodynastoidium. Let me just draw a picture of it here. You guys know about this. It tends to be a little blunted. There's C2 on the AP, and you got a little ossicle, right? That's what it typically looks like. Guys, 99 out of 100 of those are old type 2 dens fractures that somebody missed. They're not developmental. Os odontoidium, you heard it here first, are not developmental. They're old dens fractures. Type 2 dens fractures. And they're massively unstable. And you definitely want to get flexion extension views. Even for this case, I would get flexion extension views. That's why this is so shocking to me. This is a true non-union going down below in there. So if this is an osteodontoidium, this is a developmental osteodontoidium. So great case. And,
so on the flexion extension views, then you're looking for ADI greater than 3 millimeters?
Yes. You could look for, I'm getting an echo. Are you guys hearing an echo?
Yep.
Oh yeah, I was going to say it's going to drive me nuts here. Yes, you could look for a big ADI space, but chances are the transverse ligament is just fine. Yes, you'd look for that, but what you're really looking for is if that dens slops around. If C1, if that dens slops from flexion extension on top of C2 at that interface, is that interface hunkered down with the kind of fibrocartilage? It looks lucent. Is what's in there? Is there something kind of still holding it together, or is that going to be unstable? But yeah, definitely look for the transverse ligament. It'll probably be intact, but look for instability at that segment. So an os odontoidium, typically, a typical os odontoidium is a residual of a type 2 dens fracture. A typical os odontoidium is a residual of a type 2 dens fracture. This is a weird one. This is like a real developmental one. An ununited secondary growth center, as the doc said. Exactly right. But typically, they're higher up lucency, and it's an old type 2 dens fracture. Okay, this is the last case. We'll have a quiz question on this, and then I want to just make sure you know the questions, and we'll be done. 25-year-old male with low back pain, a history of food poisoning 2 months ago. All right, detection. Where's the abnormality? This is the left side of the patient with that little yellow L that I put in. All right, what's abnormal here?
Left SI joint.
Excellent. Excellent. Good pickup. Left SI joint is bad. All right, if I were to ask you to describe it, give me some of the words you might use for a description.
Sclerotic.
Roughening
Good.
of the articular surface.
Good. Good. All right, good enough. Sclerotic, rough, articular joint margins, and maybe a little wide.
Yeah.
If you want to get fancy, you could say indistinct. But at the end of the day, hey, do you like this for unilateral sacroiliitis, unilateral inflammation of the SI joint, or bilateral? What's your gut tell you? Is this more unilateral or bilateral?
Unilateral.
I agree. And here is an important thing, you guys. I understand that when we say sacroiliitis, we're thinking AS, and we're thinking psoriatic, and we're thinking, we used to call it Reiter's disease, but we don't do that anymore. We call it reactive arthritis. Yes, we're thinking those seronegative spondyloarthropathies. But here's the kicker. If you get purely unilateral, yes, it could be these two. AS is typically more bilateral. sacroiliitis. But if you get purely unilateral, you don't think AS, you don't think psoriatic, you don't think Reiter's, what do you think?
Infection.
Yes, very good. Infection. That is important. Infection is the best thought for unilateral sacroiliitis. All right, you guys did well today. Great cases.
Dr.
If I
Ed?
do, yes, questions on any of the cases? Hit me.
Yeah, if you had some previous significant sprain type trauma to the left SI there, could you end up with juxtaarticular sclerosis like that?
Yes, you could, but if it then that would be, if it was old trauma, typically you're going to have OA, and the kicker is the joint might be irregular. I admit it might be sclerotic. I admit with OA from old trauma, but here's how you tell the difference: the joint will be narrower with OA.
Okay.
And you will have, almost always, you'll have inferior osteophytes at the joint. Inferior osteophytes at the joint. That is how you tell the difference.
Okay, thank you.
Yes, other questions? Other
How
questions?
about- Let's go back to that. You don't have to go back to it, but let's talk about the 99 or 95% of the time, type 2 Dens fracture. So obviously, if you do flexion extension studies and it's unstable, you wouldn't want to adjust it. So question one is, if it were unstable when you did that, you'd want to send them to an ortho. Question two, even if it looks stable, would you still want to avoid aggressive upper cervical adjusting on that?
Yes and yes. So here's what I would say. I would, if it's unstable, the centers for cardiac and respiratory function are right there. You don't want to mess with it. You get them to a surgeon you play golf with. Somebody who's good, somebody who's conservative, somebody who respects you, of course. Either an orthopedic spinal surgeon or a neurosurgeon who does spine. Second question is, the key word was aggressive that you said. Would you avoid aggressive? Well, yeah, I would avoid aggressive adjusting there, but not any adjusting there. I would think that you could do some things, you know, non-aggressively. Certainly, you know, you can adjust however you want, you know, above and below. But right at that level of 2, even so, you probably, if it's stable, if you've shown it's stable, then you might still do some light adjusting, some activator, some this and that, and be just fine. You just start light and get more aggressive over time, in my opinion. This is more of the art discussion, right? This is more of the art. No one's proven any of this stuff. This is just using our clinical gut. But I agree with you on both counts. Other questions? Good questions. I'll go back to anything too. Okay, so, all right. An aneurysm is above 4 centimeters. Aggressive pathology of the rib can show up as an extrapleural sign. The best x-ray to follow up a lung lesion that you find on a thoracic spine film is a P to A and lateral chest films. If you have a flexed spinal segment, that could be old trauma. That's kind of a duh, but there's some recent research that's coming out that's proving that, and that's kind of fun. An osodontoideum is typically an old type 2 Dens fracture, and unilateral sacroiliitis is infection until proven otherwise. Okay, guys and gals? If there's a gal on it. All right, good to talk to you guys. I'll bring another few good cases next time I'm up to bat. Some different stuff, and we'll just keep doing radiology practically like this.
Awesome, very good.
Good stuff. Thanks, Dr. Rich.
Hey,
You bet.
Jeff, is Jeff
You bet.
still on?
Yes.
Hey, Jeff, this is Joe. I can't remember if I did the test from last time, so when you send it out, send me the last one too.
All right, will do.
Where are you
All right.
at home?
Thanks, everybody, and I'll send out the email this afternoon that will have the link to the test, and let me know if you have any questions. Thanks, Dr. Rich.
Yep. Should be pretty easy. That little quiz. So thanks, guys, for the opportunity. Thanks, Jeff, for the opportunity. We'll see you in a month or 2 months or whatever.
Sounds good. Take care.
Okay. All right. Thanks. Bye.